Yeah, like
All right. So, good evening, everyone. Welcome to another episode of Delhi Ophthalmic Society Postgraduate Education Program, what we like to call as DOS-PEP. So, this is a wonderful initiative taken by the president of Delhi Ophthalmic Society, that is Professor Rohit Saxena sir, and the entire executive team, and spearheaded by Dr. Praful Maharana sir. The course coordinators are Dr. Pranita, Dr. Pallavi, and myself, Dr. Puneet Jain. Today's lecture will be given by Dr. Harika, and it is on anophthalmic socket and implants. And it is a surgical video-based teaching class, and is very relevant, especially with respect to short cases and short notes in the exam. It can also be a long question in the theory exam. So Pallavi unfortunately couldn't join us today, but Dr. Pallavi is one of the course coordinators for DOS-PEP. She is a fellowship trained oculoplasty surgeon and is a RPC AIMS alumnus. Currently, she is doing private practice, and she has more than 30 peer-reviewed publications and book chapters, and is also a invited faculty at national and international meetings. Myself, I am Dr. Puneet Jain. I am in charge of oculoplasty and ocular oncology services at Sharpside, New Delhi. And let's put the limelight on our teacher today, Dr. Harika, uh, who is also a RP Center AIMS alumnus. She has done a senior residency from Sarojini Devi Eye Hospital, Hyderabad. She's done a long-term fellowship in oculoplasty, ocular oncology, and patient athletics under the mentorship of Dr. Santosh Sonawar. She's also done work at Regional Institute of Ophthalmology, Sitapur. She is currently the founder and director of Eye Focus High-End Aesthetics at Vijayawada, and she has a huge list of awards to her name. Uh, the latest being the IGO Silver Award in 2023. So, Dr. Harika, I'll give you the stage now, give you the mic now. Over to you, please.
Thank you, Dr. Puneet, for such an introduction. I can't share my screen. Sunilji, should I stop that video to share this?
you can continue sharing, doctor.
But I can't see my desktop while I'm sharing.
It doesn't matter. You can share. We will be able to do it.
No, but,
So, right now your screen share is off. So, first you share your screen and then look for your presentation.
I can't, once I click the share, I can't see my desktop here.
We can see your desktop.
Yeah, we could see. You can open your presentation, then do the screenshot, please.
Okay.
Right.
Right. Thank you. So, very good evening. Thank you, Dr. Puneet, for an introduction. And I thank DOS for having me in this session today. So today I'll be talking about the ophthalmic socket and implants. So to start with, what is an anophthalmic socket? So anophthalmic socket is an absence of an eyeball with the presence of orbital soft tissues and the eyelid structures. So if we have to classify this anophthalmic socket, it can be congenital or secondary to any surgical procedures like evisceration and enucleation. So congenital anophthalmos.
Doctor, can I just stop you for a minute? On the Zoom window, you will have an option of view. Can you just hide self view on this, because we are seeing a thumbnail of your picture. Just on the Zoom bar. Or you can stop for a minute. You can stop share for a minute.
Should I stop share?
Yes, please. On the top right hand side, view, there is a view option, right? With the dots,
yes.
9 dots. Just click on it. Hide self view.
Is it okay now?
Yes, you can now share, because we are getting a thumbnail of the picture.
Is it?
Yes, we getting it somehow.
Yeah. So this congenital enophthalmos is usually nothing but a failure of ocular structural development. It could be either failure in the development of a neural tube induction or in the formation of the optic vesicle or a cup, or altogether it could be degeneration of already formed optic tissues. So either of this can lead to a congenital enophthalmos condition. And more commonly, it is interchangeably used with a severe microphthalmos. That is, there is some amount of eyeball contents present, but they are sparsely seen in the clinical or in the radiological view. So here, so when we have this doubt that whether it is really an enophthalmic condition or a microphthalmic condition, we can take the help of an imaging, right? Like here where you're seeing in the left, we can see a proper eyeball, but in the right side, you can't see any eyeball, but you can see some orbital soft tissues herein. So etiology of congenital enophthalmos, it could be again idiopathic or sporadic changes could be there, or some amount of inherited patterns are also there in the literature who describe dominant inheritance, recessive or any sex-linked, and certain amount of chromosomal deletions like 7p15.1 have been noted in this enophthalmos and also cryptophthalmos conditions. So now coming to the surgical causes of this enophthalmic socket. So evisceration is nothing but the removal of the entire intraocular contents of the eye, leaving the orbital shell, the optic nerve, and the extraocular muscle attachments intact. Like here you can see there is an optic nerve which is intact, the scleral shell is still there, the extraocular muscles are seen attached. So we are placing an orbital implant within the cavity of a scleral shell. So this is evisceration. So what are the indications of eviscerations? Indications of evisceration, the most common and important indications are panophthalmitis and expulsive hemorrhages. So expulsive hemorrhages are rarely seen, but once it happens, evisceration is the treatment of choice. And contraindications. Contraindications is phthisis bulbi, suspected in an intraocular malignant tumor, and cases with the risk of sympathetic ophthalmitis. So if you have any doubt that there is some tumor inside the eyeball, you have to image it and then only plan your treatment by evisceration or enucleation or some sort of chemo or radiotherapy. So this is a very, very important thing where you have to rule out the intraocular malignancies. So what is enucleation? Enucleation is nothing but a surgical removal of the entire globe with portion of the optic nerve from the orbit. So as you are seeing here, the complete globe is removed. Along with it, certain part of the optic nerve and the optic nerve sheath is also involved. So we are removing the entire globe in toto. So I see a lot of postgraduates getting confused between evisceration and enucleation. So like we have seen here, the optic nerve is intact. This is the scleral shell and the extraocular muscles are there. Here we are removing the eyeball in toto. So basically there is no optic nerve here in the enucleation because we are removing the optic, the eyeball along with certain part of the optic nerve. The rest is allowed to retract. And regarding the extraocular muscles, when we are doing myoconjunctival technique, certain part of the muscle is attached to the fornices. So other than that, rest of the eyeball contents are completely. Right. Now coming to the indications of enucleation. So most common and absolute indications for enucleation are any intraocular tumors. They could be retinoblastoma or any malignant melanoma. So intraocular tumors, we should not eviscerate and we have to go for enucleation. Next is trauma. So if there is a severe trauma and the eye has no projection of perception of light, and we need to be very sure that the other eye did not develop any sympathetic ophthalmitis, then enucleation is the treatment of choice. And the other relative indications would be a painful blind eye, and for cosmesis, especially in cases with phthisis bulbi, endophthalmitis, which is not responding to any conservative in the medical management, and certain sympathetic ophthalmitis cases also, we need to go for enucleation. Here, one thing I wanted to stress is in a painful blind eye or simply phthisis bulbi as well, you need to check for the ciliary tenderness. So if you see that the ciliary tenderness is not there and the patient is not willing for surgery, then you might as well go for just the scleral shell on the top of the eyeball. But if you notice that there is some amount of ciliary tenderness, there is no use of placing a scleral shell because the patient cannot tolerate it. So the ideal treatment of choice there in that situation would be to go for enucleation. And one important thing, one contraindication for enucleations. In panophthalmitis cases, you should never enucleate. Why? Because in enucleation, we are cutting the optic nerve, and panophthalmitis is nothing but the infection is completely there in all the layers of the eye. So with the cut ends, from the cut ends of the optic nerve, that infection is going to travel and it can lead to meningitis. So this is very, very important take home point for you people, that panophthalmitis is a contraindication for enucleation, and in any case of panophthalmitis, you have to eviscerate the eye. Now, so let us see some surgical steps of enucleation. So before starting the surgery, you need to mark the medial end. So why it has two implications in this. One, it helps us in histopathology. Say if suppose after sending the sample to the histopathology, if they say that there is some active tumor in the medial side, or there is some scleral involvement by the tumor, or there is some infiltration by the tumor, so that is useful. And also in the when we are doing myoconjunctival technique, so when there is a loss of muscle, so it is very easy for us to retract. So for those conditions, we need to mark the one end. So usually our practice is to mark the medial end. So it is the surgeon's choice. It could be anything. And next is to do a very clear peritotomy. Here it is very important to not to waste any of the conjunctival tissue. So a clear peritotomy, you see. So here end to end. So we have to hug the eyeball when we are doing this peritotomy with the scissors, so that no millimeter of conjunctiva is wasted, because conjunctiva is very crucial for us in the end of the surgery for the conjunctival closure. A good conjunctival closure is very, very important for a aesthetic outcome, and also it helps the implant to stay in place with offering a protective cover. So once we are done with the peritotomy, here now we are taking the tenotomy scissors and we are dissecting out between the Tenon's fascia and the globe. So you can see how nicely we are separating out the tissues there between the tenons and the globe. So we are basically freeing off all the unnecessary additions because we need to remove the eyeball. And next step is we have to tag all the 4 extraocular muscles. Again, we usually start with the medial rectus, then inferior, lateral, and then superior. So we need to tag them with a muzzle hook and double bridle. So just 1 or 2 millimeters near the attachment of the recti. We take one traction suture with 40 silk, and then another suture there behind with a 60 vicryl, and then we transect with the help of a bipolar, or short of it, we can use an artery forceps and then cut with a scissor. And then we take the obliques, the superior and the inferior oblique, and then we'll just cut and allow them to retract back into the socket. So once we are done with it, we have to carefully place a scissor, a long scissor. We have to stump the optic nerve carefully, and we need to go back and give one bold cut where the eyeball is coming up. So before doing that, it is very important to prolapse the complete eyeball anteriorly and then give a cut. So here you can see that giveaway feeling. So after that, we need to remove the eyeball and wait for the hemostasis to set in, and we need to examine the eyeball in toto. And this is the what you're seeing is the posterior tenons here. So it is a posterior tenons in which we are going to place an adequate size implant. And so regarding the implant sizes, we'll be just discussing in the next couple of minutes. So it is very important to give a very good suturing to this posterior tenons, because that is the first layer of the cover to our implant. So once we thoroughly suture this posterior tenons, so now you can see the posterior, we are suturing the posterior tenons here. And this is the myoconjunctival technique, which I was saying. So basically, we are adhering this muscle to the fornices. So to all the fornices, we'll be attaching this to the medial, inferior, lateral, and the superior, so that they will have certain amount of movement of the prosthesis after the surgery. Okay, so this is how we anchor these muscles to the fornices on all the 4 quadrants. So this is very critical to give a reasonable amount of movement and cosmesis to the patient after we place the customized prosthesis. So after placing this myoconjunctival suture, so you can see we have to tie them there near the fornices. So later on, we'll suture the anterior tenons and the conjunctiva. And then we place a conformer and then do a suture tasseraphy. So this suture tasseraphy can be put in place for 2 weeks, and then we can remove the tasseraphy in 2 weeks, and customized ocular prosthesis is placed after 6 weeks of surgery after thorough socket healing. So in the evisceration, the other steps are similar. Here, what we do is after peritotomy, we give a incision to the near the limbus, and we remove the corneal button and scoop out all the intraocular contents. So after scooping out all the intraocular contents, again it is the same. We place an implant. We can use different sclerotomy techniques to place an adequate size implant. Again, regarding the implant size, we will be discussing now. So it is very, very important how to calculate the implant size. So in enucleation, we can use an intraocular sizer. We have an intraocular implant sizer. So we can measure it and we can put it inside. So if you feel that is a lesser size of an implant, you can remove it and place a larger size of the implant. And short of it, you can just take the axial length of the contralateral eye and subtract 2 millimeters and put it there. And in evisceration, so it is very important to calculate. So how do you calculate? So you need to take the axial length of the contralateral eye and you need to calculate the circumference. For example, let us take the axial length of the contralateral eye is 24 millimeters. So with that axial length, we need to calculate the circumference of the eye. So circumference of the eye is nothing but a circular structure. So with pi d here, instead of 3.14, we are considering pi as 3. So when we calculate the circumference of the eye, it is 24 into 3, which is nothing but 72. Right. So now we have the circumference of 72 millimeters. So what is happening in evisceration? We are removing the corneal button and 1 to 2 millimeters of the limbal tissue as well. So we need to considering this corneal button of 10 millimeters and 2 millimeters of the limbal tissue on either side. So we need to subtract that amount. So 72 minus 12. So we are left with 60. Right. So now this is the circumference we have got. So if we have to convert it to the sphere or the round structure, again, we have to divide it by 3. So now 60 by 3 is 20 now. So here in the evisceration, we are overlapping the implant with the sclera. So we are overlapping. So we need to subtract again 2 millimeters because we do not want tight suturing. Why? Again, if we leave with the tight suturing, there are high chances of implant extrusion. So that is now that is why we need to subtract 2 millimeters and then decide the adequate size. So if I take the axial length of the contralateral eye as 24 millimeters, now with this calculation, I get the ideal implant which I have to place is 18 millimeters. Now, so what is an adequate enophthalmic socket? So we have done evisceration or enucleation and I'm left with a socket. So I have to decide whether my socket is an ideal socket or not. So what are the characteristics or factors we consider to say a socket is an ideal one? One thing is it should have an adequate volume. Adequate volume is by placing then adequate size of an implant and healthy surface. So if we really do a good peritotomy and close the conjunctiva very well, the surface will be healthy and it will heal very well after 6 weeks of surgery. And adequate fornices. So this is very important when we are doing this myoconjunctival technique and we are doing this sutures like I have shown. So if we do it properly, the fornices would be really adequate. And we should also see that the normal position and the good position of the eyelids are maintained. So otherwise, if any of these things are not proper, the patient you usually end up having certain entropion and certain standoff issues. And again, the processes should be well fitted. So if all these factors are there, then we consider it as an ideal enophthalmic socket. So I'll just show you a small video. This is a video I have made during my fellowship at CFS. Okay, so
an ideal socket can retain an ocular prosthesis well in place. Contracted socket is defined as the shrinkage and shortening of all or a part of orbital tissues, causing a decrease in the ponytail depth and orbital volume, ultimately leading to an ill-fitting ocular prosthesis. Various classifications were given for the contracted socket. The contracted socket can be classified as socket with surface loss, socket with volume loss, socket with both surface and volume loss. Measurement of the vertical surface, which includes superior palpebral conjunctiva, inferior palpebral conjunctiva, Conjunctiva in the socket without any stretching. Measurement of the horizontal surface is the horizontal palpable fissure. Indirectly, if we notice only shallowing in the superior fornix while we press the inferior fornix with a wet cotton pad, that implies a moderate contracted socket and can be managed by an amniotic membrane graft. But if the superior fornix moves or shifts down during this procedure, it implies a severe surface loss of the socket and mucous membrane graft is mandatory. In this video, we
So here we need to discuss this. So as I have mentioned, a good surface and a good volume is very, very important for the socket to correctly fit the prosthesis. So when we are seeing this, if say the patient comes and says that the prosthesis is not fitted properly, or if the patient is having certain discomfort, we need to assess these things. So I'll just discuss the management. You have seen what is a contracted socket briefly. So when there is no surface loss and there is no volume loss, if there is certain amount of just shallowing of the inferior fornix, then you can go for this fornix formation suture, or you can place a prosthetic reprosthesis with a little thick material. If you say there is a mild surface loss, then again you can just inject 5-fluorouracil injections along with this fornix formation sutures. They usually do well. Or if it is little more, you can place an amniotic membrane on the surface. But if you see the surface loss is severe, so all these things would not work out, but you have to go for a mucous membrane grafting, and those sockets heal very well. So, and if the surface loss is accompanied by volume loss, so then we need to take care of both. So then in those cases, we need to go for a dermis fat graft. Here the dermis, it acts for the surface, and the fat, it fills for the volume. So if so that is when we have both surface and the volume losses. And when it is again very severe, then that's it. Those are extreme cases where we have to go for this exenteration prosthesis or the vascular pedicle graft.
Straight the socket.
Yeah. So this is the classification. I'll just highlight more. So here grade 1 is just the shelving of the inferior fornix. So other fornixes will be fine. Only there is shelving of one fornix. And grade 2 is both the upper and the lower fornixes are inadequate. And grade 3 is there is upper, lower, medial, and the lateral fornixes are inadequate. And grade 4 is all the fornixes, and along with that, there is the reduction in the palpebral aperture in both the horizontal and the vertical dimensions as well. And grade 5 here, they have classified it as a recurrence of a contraction of the socket. After, so you have reconstructed once, twice, but still there is a recurrence of this socket contraction. So that is usually classified as grade 5. This is Gopal Krishnan classification, usually asked in your exams. Okay, so what could be any dreaded complication of this evisceration or enucleation is nothing but an implant extrusion. Very, very important. So in certain cases, in very bad infected cases, you see the conjunctiva is really friable, very highly inflamed, and those cases, you will have high rate of this implant extrusions. So how do you manage these implant extrusions? One is definitely you have to give proper antibiotics to take care of that infection. So along with it, so here in the picture you are seeing a very, very severe implant extrusion. You see, other than that, if you see a very small extrusions, you can just suture the dehiscence, or otherwise you can use some autologous serums along with it. And if it is large, you can cover it with a scleral patch graft. But before doing all these things, you have to be very sure that there is no infectivity left behind. Right. So otherwise, another option, if it is very bad, you can just remove the implant, let the socket be free of infection and let it heal. And then you can place a secondary implant at a later setting. Now, so moving on to the orbital implant. So now we have seen the evisceration, the enucleation, and we need to place an implant. So which type of implant you would be placing in these surgeries is again important. So we have a wide range of implants over the years. So we can just classify, and this orbital implants is again a very important question for you, even in your theory and even in Viva, they would be asking. So this is very important. So we can classify this orbital implants into non-integrated, semi-integrated, integrated, bio-integrated, and biogenic. So we'll be discussing all this in detail. So what is this non-integrated? So in this, while I'm talking about integration, we will be talking integration in terms of integration with the orbital structures or the prosthesis. So if we are placing an implant, the implant would be integrating with either of these two or with both. right? So in the non-integrated, there is no integration with the orbital structures or the prosthesis. So the most common ones which we are using these days is PMMA and the silicone implants. And semi-integrated. Semi-integrated is there is some sort of mechanical integration with the implant. Okay, so mechanical integration in the sense we are suturing the muscles along with the suture to the implant. For example, I'll show the picture of the Allen's implant. So Allen's implant, it has certain grooves where we suture the muscles through those grooves. So we are providing some mechanical integration with the orbital structures. But again, there is no integration with the prosthesis here. So these are the semi-integrated ones. Next, we come to the integrated. So integrated in the sense, so there is some integration with the orbital structures and also along with the orbital structures with the prosthesis also there is some integration. And one more important point, so all these semi-integrated implants can be made integrated with the help of a peg. So basically with the pegging of the orbital implant to the conformer, these semi-integrated things become integrated implants, right? So next is a bio-integrated. Bio-integrated is nothing but there is some biological integration. See, for example, this hydroxyapatite or porous polyethylene or aluminum oxide. So these are nothing but a biological material. So what happens is there is some sort of fibrovascular tissues penetrating through the implants and forming certain integration, biological integration. So it could be with or without integration with the prosthesis. The last is the biogenic. Biogenic is a natural tissue. It could be an autograft or an allograft of a natural tissue with direct integration with the orbital structures. So the examples of this is dermis fat graft and the cancellous bone. Now, coming to what is the characteristic of an ideal implant. So we have discussed a wide range of implants. So what could be an ideal implant? One is it could mimic a normal globe as close as possible. Second is it has to replace sufficient volume, but it has to allow for a prosthesis of adequate anterior chamber depth. And it should have a minimal rate of exposure, extrusion, infection, and inflammation. And it should be non-antigenic and biologically inert. And it should provide socket motility transmitted to the prosthesis. It should be completely buried, simple in construction without projections or angulations, which erode the conjunctiva. So here you'll understand when I show you the Allen's implant, they have these angulations or projections, and they are, quite harsh on the conjunctiva, leading to granulation tissues once we place them. And those implants should be lightweight and well centered. So initially, to start with, these implants are made up of glass, so they used to be very heavy. So in contrast, these lightweight implants like silicone and PMMA. So PMMA is even more lighter than the silicone, right? So these lightweight implants are centered well within the muscle cone, and they are anchored to the orbital tissues, and this leads to a very minimal chance of these extrusions or migrations. So able to integrate to the extraocular muscles and soft tissues without any fibrous additions, it forms an ideal implant, and it should be able to be directly integrated with the prosthesis for transfer of motility, and it should be obviously affordable and easily available. So these are all the characteristics of an ideal implant, but it is for us to choose which implant is ideal in a particular case to the patient. So these days what we are using is a PMMA or a silicone implants. They are usually lighter in weight, and they give a reasonable amount of motility and good cosmesis after the surgery. So what are implant-related causes of this socket contracture? So once we place the implant, if the implant size is inadequate, so there could be an implant migration within the socket. So what happens is the cosmesis is impaired in such cases when the implant is migrating. Implant extrusion we have already discussed, and implant exposure. So these are the implanted related causes. So once the implant is not properly placed, obviously it leads to socket contracture. Right. So we'll just see certain non-integrated implants. So this is what we are talking about, the PMMA and the silicone spheres. So these are non-porous. They do not integrate with any of the orbital tissues. But having said that, they do not integrate it. Once we place in, there is a certain pseudo capsule around the implant which is formed and which keeps them adhered in place. So non-integrated are ideally pseudo-integrated with certain amount of fibrovascular pseudo capsule developing around the implant. So they do not allow any muscular attachment unless wrapped. So here we can wrap these non-integrated implants with some scleral shells. So we have this dona scleras available. So if we wrap these implants with the sclera and then place, again they become semi-integrated. Right. So these are non-integrated implants. So advantages is they're cheap, they're easily available. They usually have a smooth surface, no angulations or no projections. They have less complication rates, and these can attach muscles if wrapped sclera. I was just discussing that. And disadvantage is poor motility if not wrapped. This is not 100% true, because as I discussed, they'll form a certain amount of pseudocapsule so that they are well placed in the socket there. And one important thing is, especially in cases of retinoblastoma, where the patient might need radiation at a later stage, these implants are these are high recommended and very safe to put, because we can't place any integrated implants in such patients, because any radiation, with the radiation effects, there will be some effect on the fibrovascular tissues, and these implants tend to dead out. Okay, so these implants tend to dead out and expose. So for in those cases, especially in the retinoblastoma cases, we have to place these non-integrated implants. Coming to the semi-integrated implants. So this is the Ellen's implant which you are seeing. So we have these certain grooves here. So we can attach the muscles along with the sutures through these grooves. So there will be some sort of a crisscross integration when we place. But the side effects of this is these angulations or the projections which we are seeing. So they are harsh on the conjunctival surface, and they can lead to, certain more frequent infections or granulation tissues, and obviously ill-fitting prosthesis. So these are the concerns when we use this semi-integrated implants. But yes, they provide good motility, and they also are inexpensive. And disadvantages, as we discussed, are irregular anterior surface, discomforts and rate of erosion and extrusions are high, and special customized processes are needed to fit its shape. So a proper mold is very, very important when we are using these implants. Fully integrated implants. So fully integrated implants are again porous. They allow this fibrovascular growth of the orbital tissues for full integration. So basically they have tiny pores, as you are seeing here, and through these pores are natural biogenic, the fibrovascular tissues go in and growth, and these implants become a part of our body. So most commonly used among these are hydroxyapatite, aluminum oxide, and polyethylene porous. So this is just a detailed description. So hydroxyapatite is composed of a biocompatible ceramics matrix, and it is almost the same as our human cancellous bone. It is permanent. They do not resorb, and they can be drilled with a motility peg. So basically they can be drilled, and with a peg they can be attached to the prosthesis. And polyethylene, it is made up of polymerization of ethylene molecules and a high temperature and pressure. They have less tissue friction. They're not brittle, and muscles can be attached without the wrapping on the tunnels. And aluminum oxide, it is inert easily into the insert. It can insert easily into the socket. They do not cling to any surrounding tissues, and the connectivity is really high with this aluminum oxide, and it can also be easily drilled and pegged. So as we have discussed in the starting of this talk, so we see certain anophthalmic cases or microphthalmic cases. In those cases, we take the help of these expandable implants. Okay, so what happens is they expand in vivo and they stimulate the orbital growth. So because these congenital anophthalmic cases, the sockets are really very small. So in those conditions, we have to stimulate the orbit. When the socket is very small, there is no eyeball content in this. Usually that orbit do not grow. So in order to stimulate this orbital growth, we need to have some orbital implant in place. And because the size is very small, we need certain expandable implants which stimulate this orbital growth. So the indications of these expandable implants is the volume deficit in the orbita, the congenital anophthalmos or microphthalmos. And here we have the silicon balloon expanders, hydrogel sockets, and orbital expanders. So what happens is, in these cases, we have to serially expand. Say now, today we have inserted an expand or a hydrogel socket here. So we need to evaluate them after 3 months or 6 weeks, 3 months, and then we need to replace it with a larger implant. So with the sequential change of these implants, the socket gets larger, and it will be suitable for placing a good customized processes for good cosmesis. Yeah, that's it. Thank you so much. We can take any questions, if any.
So, very detailed and elaborate presentation. Personally, I loved a couple of slides. Though the entire presentation was amazing. The slide on the type of implants that you had shown, I remember there are so many MCQs. Which of the following is not an integrated implant? Which of the following is not a semi-kinetic? And then during our PG time, when we used to read all these, Allen's, Castrovillo's implant and everything, we had no head and tail of what they're asking. So I think the exposure does that, and a lot of slides. Obviously, you can take screenshots. You can just pen them down in your short notes. You can answer a lot of Viva questions and MCQs with the help of the presentation. So this is a recorded series. So I'm sure those who have not joined in today can take the maximum benefit out of your teaching later on as well. So a couple of things. If you do land up, so this is strictly from a PG perspective. So if you do land up with a short case, let's say the patient has contracted something. So what would be your salient features right from history to examination and to management uh, with respect to a short case in the exam?
Yes. So first, as we have discussed, if we have a case in our exam, this socket examination. So first you need to first you need to take a proper history. So what is the cause of the an ophthalmic socket? So was the patient is having any tumor, or the patient had some trauma? So what was the cause and what is the procedure has been done? So most of the times the patient won't be sure whether the procedure is evisceration or the enucleation which has been done in them. So we need to take that history properly as well. And if possible, we need to ask them for the records to see whether the implant is placed or not. So that comes in the history. So first is the etiology, what has happened and which procedure has been done and whether the implant is placed or not. So these 3 points are very important when we are asking the history from the patient. So once we have that in mind, then we should go for the examination of the socket. So examination of the socket, again, it starts from the measurements as we have discussed. So we need to start with the measuring of the horizontal feature and the vertical feature, and then go and see the surface, how the surface is looking, whether the surface is healthy or not. So in the video, as we have discussed, so you need to see whether the surface is adequate or there is some contraction of the surface. So I'll just emphasize it again. So if you want to see whether the surface is adequate, what you need to do is just put a drop of local anesthetic, topical local anesthetic into the socket and take the help of a bud. So, and you with the bud, you try to press the lower fornix. So when you press the lower fornix, if nothing is moving, if the superior fornix is not moving, or there is a no or a very little movement, then it could be an adequate socket or a grade 1 contracted socket. Or otherwise, when you are pressing with a bud, if the complete socket or the superior fornix also shifts down, it means that the surface is inadequate. Why? Because when we take the socket, the central, the palpebral conjunctiva and the tarsal conjunctiva, for the fornixes, the socket itself, the surface, at least it should be 20 millimeters. And for the superior fornix, it has to be 15 millimeters. And for the inferior fornix, again, it has to be 15 millimeters. So when that is not adequate, obviously there is some compromise in the surface. So that we will be examining the surface first. Next is the volume. So when there is some amount of implant placed, so usually there won't be there won't be a severe volume loss. But again, if the implant is not adequate, we can see the issue of this volume loss. So again, with the help of a bud, we have to just press within the socket, and then you will see whether there is an implant or not. If there is an implant, definitely we'll be hitting it a little hard. So there is an implant in the socket. What happens if the implant is not properly sized, not adequately sized, or if there is an implant migration? So definitely you will see the implant is not in the center, or it is shifting to some quadrant, the inferior temporal quadrant or inferior nasal quadrant, due to the effect of the gravity. So here, when you're checking the volume, you have to see whether the implant is there or not. If the implant is there, whether it is properly centered or it is migrated or not. So these 2 things we have to check in the volume. So once we take the surface and volume, then it is for the examination point of view, it is ideal to measure the fornices. So you can take the help of a small bud and you can measure it with a scale, or short of it, you can take the help of the Shermer strips. So Shermer strips, we can just place in the fornice and you can measure them, and you write the measurements of the fornices, and that gives a very good impression to your examiner once you measure those. So once you're done with all these things, and the final thing is you have to see whether the patient is using a prosthesis or not. If the patient is already using prosthesis, if it is properly fit, And you can ask the patient, does it fall during certain times in the routine daily activities? Does the processes stay well in place, or it is falling down? So that we can ask them. So well-fitting processes we have to make sure of. So all these things form a part of a socket examination.
All right. So, wonderful. And just to take this further, the next step would be, you might require an imaging for the patient if you're planning a surgical intervention. And in case you clinically cannot make out whether there's an implant or not, what is the implant central or migrated, then a non-contrast CT scan is sufficient to give you enough details. Uh, what Dr. Harika pointed out with respect to clinical examination of the fornices, that is, first is the bud test where you use the bud and see whether the entire conjunctival surface is moving or not. And second is the use of Shermer strip. These two are very, very important points, and they leave a very good impression. Even if don't give that good answers in management, even if you do all these things in the exam, in front of the examiner with the patient in front of you, it leaves a very good impression, and it does show that you are thorough with the oculoplasty cases at least, or with an ophthalmic socket. So that's great. I think management we have already discussed in detail. How do we decide the size of the implant? What are the various techniques? We had our previous lecture, Dr. Harika, in the series where the details of the various scleral flaps, the four-petal technique, the two-petal technique of evisceration was also discussed. So I think combining the last educative lecture and your educative lecture, I think it sums up the entire orbital management with respect to surgery, evisceration, inflation very nicely. I thank you so much for taking out time, making this wonderful presentation, and then teaching the students so much. And I'm sure that those who could not join could go back and learn a lot from your presentation for the exam and otherwise also. Thank you so much.
Thank you so much, sir. Thank you, Dr. Puneet and the DOS for having me here in these sessions. And thank you, Sunilji, for the technical support. Thank you so much.
So let me share my slide now. So next in the series, we have the next lecture. I think it's by me only. So, okay. Yeah. So today we are done with is my slide visible?
Yes, it's visible.
All right. So today we're done with the Dr. Harika's lecture, which was on an ophthalmic socket implant. And next we have the last bit of the series, which is the ocular tumors. And we'll be starting with ocular surface tumors, which will be Monday. So see you then. See you on Monday. And good night. And thank you so much, Dr. Harika. And thank you, the admin support for seamless streaming. Thank you so much.
Thank you, sir.